So starting with diabetic ketoacidosis. Diabetic ketoacidosis is the cause of metabolic acidosis. So it is found in type 1 diabetes mellitus. So I always tell my student three things. So there is hyperglycemia, glucose is more than 250. Then there are ketosis. There are positive ketone bodies in the blood and the urine. Then metabolic acidosis. pH is less than 7.30 and bicarbonate is less than 18 milliequivalent per liter. Then there is increased anion gap, that is more than 12 to more than 12. There you know the symptoms: polyuria, polydipsia, nausea, vomiting. In case of type 1 diabetes, it is due to the dehydration. Then there is abdominal pain. It can mimic the acute pancreatitis, and you can go for serum amylase and lipase for the acute pancreatitis. Then there are signs. Patient present with tachycardia, hypotension. Main important is Kussmaul's respiration, that is deep rapid breathing. Then there is a fruity odor, that is due to the acetone in the breath. Then you have to remember 4 eyes, that is infection, any sepsis, then you have any UTI, then infarction, MI, cerebral, then patient have not taken the insulin, then intoxication due to the cocaine. So various lab investigation you have to send to the lab, that is glucose, ABG, ketones, serum ketones, urinary ketones, serum electrolytes for potassium, then anion gap. And then you have to look for RFTs, that is BUN and serum creatinine. You have to look for serum osmolality, which may be elevated, but it is mainly activated in the type 2 diabetes mellitus. Then you have to CBC for looking the leukocytosis, then urine culture, blood culture for any source of sepsis, chest x-ray for any infection, then ECG, potassium related changes or MI related changes. Then main important part is the fluid. So in DKA patient, main fluid deficit is 4 to 6 liters. So you have to give 0.9% NaCl. So in first hour, you have to replace 1 liter of the fluid. That means you have to give 2 bottles of NS. One bottle is of 500 ml. So you have to give 2 bottles in 1 hour, right? So after the BP stabilizes, you have to decrease the infusion to 500 ml per hour. That means 1 bottle in 1 hour. Next, you have to look for sodium. If sodium is more than 135, you have to decrease to 0.45 NaCl, that is N by 2. If more than 135 is the sodium, you can continue with 0.9 NaCl. So next is the potassium part. So we have 3 criteria in potassium. If potassium is less than 3.3, you have to hold the insulin, right? You don't have to give insulin. So first you have to replace the KCl in the form of 20 to 30 milliequivalent per hour. So it is in the form of per hour. In 1 hour, you have to give 1 ampule of KCl, that is of 15%. 1 ampule of KCl 15% is equivalent to 20 milliequivalent. So 1 ampule of 7.45% is equivalent to 10 milliequivalent. So if potassium is 3.3 to 5.2, then you have to add 20 to 30 milliequivalent of KCl in per liter. So whether you have to give in 2 hours, 3 hours, 1 liter, so in that 1 liter you have to replace KCl 20 to 30 milliequivalent. You can add 1 ampule of 7.45, 10 milliequivalent in 500 ml, then again you can repeat. If potassium is more than 5.2, so you don't have to give KCl, you have to just monitor every 2 hours. While giving potassium, you have to monitor urine output, and it should be more than 0.5 ml per kg per hour. That means if patient is of 60 kg, urine output should be more than 30 ml per hour. Next is the insulin part. Insulin should be started only if potassium is more than 3.3. This you should remember. So first you have to give the bolus dose of 0.1 unit per kg per hour. That means if patient is of 60 kg, you have to give 6 units per hour, right? Then you have to give the continuous insulin, that is of same units, 0.1 unit per kg per hour. That means 6 units in case of 60 kg patient. That should be given in 50 ml NS, and that should be given through the infusion pump. And there should be a target fall of blood glucose by 50 to 75 milligram per deciliter per hour. That means if initial glucose was of 350, right? So after 1 hour, blood glucose should be 290 milligram per deciliter, right? So when blood glucose reaches less than 250, you have to add 5% dextrose and you have to continue the insulin because ketosis is still there. So you have to monitor RBS, vitals, urine output hourly, and ABG electrolyte, bicarbonates, and iron gap after every 2 to 4 hours. When you should know that DKAs have resolved when pH is more than 7.3, bicarbonates is increased more than 18 milliequivalent per liter, and iron gap is less than 12. Then you should overlap first subcutaneous insulin dose by 1 to 2 hours. Then you should stop the IV insulin. When you should give IV bicarbonates when pH is less than 6.9. Okay, thank you.